Hello, everyone. I'm Dr. Gary Severance with Henry Schein, and Happy New Year. It's been about 3 years, actually March 23rd, 2020, when we at Henry Schein started bringing weekly and then monthly updates on the pandemic and its effect on our profession and our patients. Each one of those episodes featured the expertise of Dr. David Reznik, Chief Dental Medicine for Grady Health System. We're now expanding our subject matter, and while we'll continue to keep you informed on COVID-19 post-pandemic, we want to broaden it to cover other health issues that have an impact on our profession. So in 2023, starting with this episode, we are renaming the YouTube series to Health Concerns in Dentistry, which will allow Dr. David Reznik to share vital information on a variety of issues as they arise each month. We appreciate your continued interest, and I know you share my excitement of welcoming Dr. David Reznik back for 2023. Dr. Reznik, good afternoon.
Welcome to Health Concerns in Dentistry 2023. As Dr. Severance has mentioned, we have changed the name of this webinar series. We're not exactly post-COVID, but we're in a much better place. We know what precautions to take. And so we'll continue to cover the respiratory viruses as they appear, but we're open to covering more areas this year. So now we're going to finish up on some of the 3 respiratory viruses that have taken over. We have COVID, the flu, and RSV. And one of the things I would like to share about this is that we were so worried about a triple pandemic, everything hitting at the same time, and actually that did not occur. And so our health systems have actually been able to maintain, for the most part, a good static basis. So we're seeing a little bit of an increase in the number of cases of COVID-19 in our country, but we're not seeing the same amount of hospitalizations, and that's what's really important. We had a huge early strike of the flu. Many people got the flu before vaccination. I got vaccinated. A couple of days later, I was exposed. I didn't have time to get antibodies. I ended up with the flu for the first time in years. No, the vaccine did not cause me to get the flu. And we had RSV. The flu started earlier than normal and peaked earlier than normal. And the cumulative cases of COVID are increasing, but not nearly at the level that we've seen in the past. You can look at parts of the country. As you can see, the entire country has been impacted by COVID. Where you see the larger circles is where you've had larger outbreaks. So basically, the entire state of Florida, the Northeast has been hit really hard, parts of California and Texas. Go Cowboys. And you can see that we're not quite over this yet. But if you look at the new confirmed cases on the 7-day average, it's around 24,000. That is such a remarkable decrease for what we have been seeing even earlier this year. So the progress that we're doing, the seriousness of what we're seeing with XBB 0.15, et cetera, is not really impacting us into a terrible degree. I don't want people to let your guard down, though. I think we still need to take some precautions. I think we need to take this seriously. And when I'm talking about that, it's for when you're not in your dental practice. But when you're in a dental practice, we still need to take all the precautions that we do. There actually was a study published yesterday by the WHO that showed about 9.3% of dental healthcare workers around the world were infected with COVID. And that was before the vaccine. The United States never had that level of COVID in our dental practice, primarily because we already were doing standard precautions. And so we already had precautions put in place. We just had to add some things to make sure that we wouldn't have airborne transmission, so the N95s, et cetera. If you look at the number of cases, again, the weekly total is beginning to decrease. The deaths, now we are seeing an increase in deaths, but compared to where we've been in the past, again, that number is still very low. We reached 1 million deaths sometime last year, probably last fall. So we're not seeing a tremendous increase in deaths. The people who are most vulnerable are the people who are 65 and older, are those who have underlying medical conditions. As you can see, the number of new admissions, the daily average is about 5,600 throughout the country. Again, there's about 35,000 people with current hospitalizations, but that number is very small compared to where we've been. And the percent of people who have been boosted is about 16%. Getting vaccinated has really turned into a political football, and it shouldn't be, but I'm not going to preach about that today at all. The XBB.1.5 accounts for 43% of the new cases of COVID-19, up from just 4% about a month ago, and that's using the CDC COVID tracker. And the Northeast, the subvariant accounts for more than 72% of the new infections, according to the CDC. It's spreading very rapidly because it's been able to find a sweet spot that allows it to both hide from the immune system and efficiently affect our cells. The good news is that it's primarily an upper respiratory infection. It's not that lower respiratory infection that we saw a few years ago when there was a call for respirators and our hospitals were full, but it's still, we have a lot of unknowns. We do not know how the China pandemic is going to play out throughout the world. Now, they basically they stayed at home for a long period of time. And now that those restrictions have been lifted, they're having a very serious outbreak with over 1 million people being infected a day. So we really need to keep our eye on what's happening overseas because it could come over here. The set of mutations for XBB.1.5 create a variant that is by far the most immune evasive we have seen. It's the first documented example of a variant increasing its fitness through recombination rather than a single mutation. In other words, it's two BA.2 sublineages who have come together and they both harbor immune escape associated substitutions and infectivity enhancing substitutions. The subvariant found a new mutation that allows it to restore the ACE2 binding properties that allow it to infect and transmit more efficiently. It appears to be resistant to both monoclonal antibodies, but not to antivirals. So people who would be at risk, immunocompromised people who might be getting antibodies at the beginning, right now they're not being effective. What we have as far as our monoclonal antibodies today are not effective against this variant. However, the antivirals are, and I keep on hearing reports of people who go on Paxlovid who are getting this and literally within a day are feeling better. So the key here is if you do test positive, go to your doctor and get on Paxlovid as soon as possible because the symptoms will be greatly reduced. According to the CDC, the most common circulating subvariant, as I've mentioned, is the XBB.1.5 at 43%. It is important to note, and this is something I said earlier, that while the percentage of cases is going up, the total number of COVID cases increasing at a much slower rate. And that is enormously important. So we're seeing infections being caused by XBB.1.5, but the total number of cases is increasing at a slow rate. There is no indication yet that the severity of illness caused by this variant is greater compared to other subvariants. So this tends to be a mild disease, but if you have patients who are older, please sort of talk to them about getting the booster if they have not. And we'll go over some important information about the booster in a second. But again, this is nowcast. It just shows you how these variants have progressed over a period of time and how XBB.1.5 is now the most, 43% of what we're seeing. And then you'll see BQ1.1 and BQ.1. These are the areas in the United States, and I did a presentation in early December, and the entire map was green, which means low community transmission. Now we're seeing that that actually has changed to a degree. If you're seeing yellow, it's moderate transmission. When you see this orange or red on your screen, that is high transmission. So you can see areas in New York and Massachusetts having a problem, Alabama having a problem, but still many parts of the country are green. If you go back to when we started these webinars way back in 2020, the United States map was red. The entire country was red. So we got over that. We went to a nice place where the country was green. Now we're starting to see an uptick in community transmission. But again, the number of total cases is not increasing at a very rapid rate. If we look at wastewater surveillance from the CDC, they do track this, and they can tell which kind of variants are in the wastewater in over 1,300 testing sites around the country. 80% of those sites are reporting moderate to high levels in wastewater. About 58% of the sites reporting wastewater data are currently seeing some of the highest levels for those since December 1, 2021. So since a year ago. About 33% of the sites are experiencing a decreased level, and about 56% are reporting an increase. So I think the key here is we are at a great place. We're able to go to movies. We're able to go to football games. We're able to get ready for spring training, all the fabulous things that we haven't been able to do for a period of time. But please don't let your guard down. I think that is a message I'd like to get across today. If you look again at levels of infectivity based on wastewater surveillance, you can see the areas in red have basically high levels, but those levels are actually going down. Then you have the number of levels that are moderate. Some of those are beginning to go down. New sites with nothing showing up are actually beginning to go up a little bit. But you can see throughout the country areas where you have high levels of transmission. Atlanta is one of those areas. If you look at New York City, there's high transmission. You can see for yourself the parts of the country where we are seeing high levels in wastewater sampling. If you look at vaccination, the percent of people who have been completed the primary series of getting the 2 vaccines, you can see how well the Northeast has done with 90+% being vaccinated, California doing well, the South being a little bit lower. The South always is a little bit lower when it comes to vaccination and healthcare issues. And you can look for yourself. When we look at the completed primary series of adults age 65 and older, again, you can see Northeast has done well. Most of the parts of the country have done okay. We've done pretty good getting the primary series. If you look at the updated booster for those over 65, the number now changes. And what we're looking at is if they've had 25% or more. So you're seeing that getting the bivalent booster is still a problem. And there are some issues with it that people, I think, are vaccinated out. Only 28% of the people in this country were vaccinated against the flu. And so we're going to really talk about why that is important. And this flu did carry a little bit of a wallop with it. So if you look at the updated bivalent booster data, it is not great. And we're not looking at 90% like we were on this previous slide that completed the primary series. We're looking at the boosted series, which is much less. If you look at this slide, which is percent of adults 65 and older with their updated booster, we've done 25% or more. We've done pretty well throughout the country. There are some areas in the South, such as Mississippi, Louisiana, et cetera, that have really not done as well a job. They're a little bit lower. But again, there has been this political battle about vaccinations, and we need to look at healthcare in a different light. I think that this is not politics, this is health, and we want to keep our patients as healthy as possible. So there's been some interesting information that's coming out from the vaccine safety data link. CDC does use a surveillance system for outcomes. And there was a concern about ischemic stroke in people ages 65 and older who received the Pfizer-BioNTech COVID-19 vaccine, the bivalent vaccine. The rapid response investigation of this signal raised a question on whether people 65 and older who received Pfizer or the Pfizer vaccine, bivalent vaccine, were more likely to have ischemic stroke in the 21 days following vaccination compared with days 22 to 42. So the primary signal has not been associated with the Moderna bivalent vaccine. I think that is interesting. What I find to be sort of problematic is that this warning came out a few days ago. And then today it says, oh, we're really not seeing it. Doing a deeper dive, we're not seeing this as being significant. So if I had family or myself that were 65 years and older, I would recommend them getting the Moderna COVID-19 bivalent vaccine booster. I would stay away from Pfizer. I think that you can't say one day that it's showing a signal that it might be a problem and the next day saying it's not a problem. Let's go with something that hasn't shown to be a problem, and that's the Moderna bivalent vaccine. The range of reported symptoms with long COVID, and I think that's important for us as providers because we're going to have to deal with people who have long COVID. And there's so many different kinds of symptoms that we see with it, and it's basically impacted between 7 and 23 million Americans, including 1 million who can no longer work. That is pretty significant. They're suffering the long-term effects of infection with the virus, according to government estimates. If you've had mild disease, the chances of having long COVID are less. If you've had severe disease, the chances of having long COVID are greater. New research from physicians and researchers at the Kaiser Permanente Mid-Atlantic Permanente Research Institute and Johns Hopkins identified 17 conditions associated with long COVID in order to better diagnose these and treat these conditions. Researchers looked at medical records of over 100,000 patients, over 30,000 who tested positive for COVID-19, and over 70,000 who tested negative for COVID-19. The 17 conditions are listed. I think that it's important to point out diabetes because we are seeing an increase in diabetes. We are seeing an increase in fatigue and malaise. There's been some issues with loss of smell and that taking a long time to come back. But we're really seeing at a period of year, a lot of these symptoms are beginning to lessen. And I think that's something that we need to realize, that if we have patients with abdominal pain, they have GI distress, anxiety disorders, and they're coming into the dentist, how we manage and how we seat our patients, how we deal with it, I think will change a little bit. And cardiac dysrhythmias is, again, another issue that we need to look at. So it's always important to stay up to date with the medical background of the people that we treat. Researchers were most interested in the conditions that developed in their patients within 30 days of a positive COVID-19 test and persisted for nearly 4 months post-test date, and conditions that developed in the 30 to 120-day period after a positive test. The key conditions included a loss of smell, cardiac dysrhythmias, diabetes, genitourinary disorders, fatigue, and chest pain. By organizing these conditions by date when a patient tests positive, researchers were able to effectively evaluate if the resulting symptoms were related to long COVID as opposed to being caused by a pre-existing health condition. Overall, about 16.5% of COVID-positive patients within the study developed at least one long COVID-associated condition within 120 days of a positive test. When working on screen patients, so let's talk about what we do for our PPE without me reading through this slide. We're doing everything that we have been doing. When we're working on aerosol generating procedures, since we have circulating flu, we have circulating COVID, we have circulating RSV, I still would recommend wearing a fit-tested N95 respirator. Some places are doing pre-screening. I recently had a medical procedure, and in this office, I had to answer questions on COVID before I got to the office. Masking in the office were mandatory. The physician had his mask on, and they don't deal with aerosol generating procedures. So we have to assume And if you look at that map that I showed where we have high transmission levels, respirators should be used when performing procedures that generate aerosols. So that's your ultrasonic scaler, high-speed handpieces, air water syringe, air polishing, air abrasion. Respirators should also be considered with procedures that generate splashing, spraying, or splatter. So you could be working on a denture. Close-fitting eye protection and face shields and gowns injections that will be changed after use. So again, I am not changing anything that we're doing today compared to what we were doing a year ago. I want to continue to maintain a healthy environment. I do work in an infectious disease program, so when patients enter our building, they have to wear a mask. We do ask screening questions in the back in the dental clinic, but again, we treat everybody as if they have COVID or they have the flu or they have whatever airborne disease or whatever bloodborne pathogen to make sure that we're providing the safest dental visit each and every time. Now, some folks have recommended with low transmission levels in the waiting room that you really don't need to wear a mask. And actually, it's a pretty good recommendation for if you're meeting like in a lunch area or you have a meeting with a small group of people that you don't mask. And that's fine. But the Association of Professionals in Infection Control and Epidemiology is strongly urging its members to uphold mandatory mask requirement policies for healthcare employees in all patient care spaces. So that's what I'm basically saying. When we go in and have a visit, we have our N95s on, we have our face shields on, etc. Now, I'll walk in a room and just say hello to a patient. I'll have on a KN95 or a regular mask. I'm just talking to a patient at that point, so they can actually see me. But before I get into doing clinical dental work, I will have on my fit tested N95, my face shield, my gown, my gloves. I actually heard of a case recently where somebody took off their gloves in the operatory, left them in the operatory, went and saw another patient, and came back and put on those same gloves. We don't do that. When we're in the dental office and we have to take off our gloves, we throw them in the trash, we perform hand hygiene, and then we go do what we need to do. We do hand hygiene before we put on a new pair of gloves. So that's very important that we do this. The recommendation comes after an update from the CDC that advises healthcare facilities to use community transmission levels as a guide when source control masking is necessary. APEX emphasized that requiring mask of everyone who enters a healthcare setting ensures the safest environment for patients. So that's why in our program, you have to have a mask on when you enter. For my staff, they stay masked, to be frankly honest. Unless we're having a meeting of our docs in the doc room, then we can take our masks off. So it's common sense. If you're generating aerosols, take all your precautions. Am I still using my extraoral evacuation system? Yes. Am I still using my HEPA filtration? Yes, I invested in this to make sure we're providing the safest visit, and I am still using it and will continue to. Source control options for healthcare providers. When used solely for source control, any of the options previously listed, a mask, a breath-setting respirator, could be used for an entire shift unless they become soil damage or hard to breathe through. If an N95 becomes wet, it is no longer effective. So we have, and the CDC came out with this recommendation, or not a recommendation, but a study that showed that if you put a level 1 mask over your N95, that it reduces the efficacy of the N95. I have staff that what they do is they put on their N95, they put on a mask over it, and they change that mask after every patient and the face shield so they don't have to take their N95 off in the morning shift. So they'll stay with the morning shift with an N95, they'll change out their level 1 masks between patients, they'll change off disposable gowns and gloves between patients. But when we're talking about source control, that's just protecting the source. If you're used during the care of a patient with a NIOSH-approved respirator face mask is indicated, and those are N95s. Remember, KN95s are not recommended for use with aerosol generating procedures. If it gets wet, they should be discarded or removed after a patient care encounter, and a new one should be donned. So you have options. If you want to change your N95s between patients, that's fine. As long as you don't have spittle, and I think people understand that when we talk, we do generate some aerosol, we do generate some moisture. If the N95 becomes wet, it's not effective. But we have so many levels of protection, from the face shield and eye protection and masking and respirator protection and all of the other things we do to keep the environment good. I think that what we're doing in our program is pretty sound. When the community transmission levels are high, source control is recommended for everyone in a healthcare setting when there are areas of healthcare facility where they could encounter patients. So if you're back in your meeting room, not so much. If you're seeing patients, yes. Healthcare providers could choose not to wear source control when they are in well-defined areas that are restricted from patient access, like staff meeting rooms, if they do not otherwise meet the criteria described below. When SARS-CoV-2 community trans levels are not high, healthcare facilities could choose not to require universal source control. I will leave that up to you and your personal choice. However, even if source control is not universally required, it remains recommended for individuals in healthcare settings who have suspected or confirmed SARS-CoV-2 infection or another respiratory disease, had close contact at 15 minutes or so within someone who has SARS-CoV-2 infection for 10 days after their exposure, or reside or work in a unit, say in a hospital where you are treating people with SARS-CoV-2. So again, I'm a little bit different. I like the concept of not having to mask in staff meeting rooms, because it actually does help with communication, I think. But when we're in patient care areas, we're in the building, I think source control is very important. But again, I will leave that up to you and your decision-making on whether you think universal source control should be mandated. It's something that we're doing to provide the safest visit. Going on to another disease, flu. Get the flu vaccine before the flu gets you. As I mentioned, I did get the flu. I haven't been sick in bed in 10 years. I don't ever want to have that again. And the vaccine this year was actually effective. The vaccine hit the targeted components of flu. Actually, and the flu season got up to a very quick start, and red flags suggested we were going to have a very, very bad flu season. But the early onset did not lead to a crisis in our healthcare systems. There have been times that the flu has made my hospital actually get mobile units to put people in, because we were filled to the brim with people who had flu who were very, very ill. We did not see that this year, and that has been a remarkably good thing. The latest data from the CDC and Prevention's Flu View reports seasonal influenza activity remains high, but continues to decline in most areas. Again, January is a bad month for the flu. December is a bad month for the flu, but we saw the flu hit very, very early on. And now you can see how the levels are truly going down. And so I think that is very important. Again, take precautions. Hand washing is so important. Proper hand hygiene of that 20 seconds, whether you're using an alcohol-based sanitizer, whether you're using soap and water. And remember, bar soap isn't the best thing to use when you're doing hand washing, because it can contain bacteria. So liquid soap is actually recommended. I always like bringing up this point about what's more effective with non-soiled hands. Is it the alcohol-based hand sanitizers, or is it soap and water? And the actual answer is the hand sanitizer. If for some reason your hands get soiled, which should not happen in the dental setting, but if for some reason your hands get soiled, then soap and water is more effective. So that's just a little bit of an addition there. If you look at the seasonal view vaccine, if you look at the levels of where the areas are high, you can see, you can judge this for yourself. You can see that Texas, for instance, I must bring them out because of Cowboys beating my Buccaneers, and Florida both have high levels, but we're not seeing very much purple. If I were to give this a presentation in November, in early December, a whole country would have been really dark with very high levels. But we see many parts of our country are having low or minimal levels, and that's good. If we maintain our precautions using hand hygiene, um, masking in the dental setting, doing what we normally would do, we can reduce transmission. So, as I just said, it continues, but it's declining. Of influenza A viruses detected in subtype during week 1, 72% were influenza H, H3N2, and 28% were influenza H1N1. Both of those were contained in the vaccine. So that is really important. If you got the vaccine, the chances of breakthrough were greatly reduced because for once we actually got the right subtypes in the vaccine. 5 influenza-associated pediatric deaths were reported this week for a total of 79 pediatric flu deaths reported so far this season. Please take care of your little ones. We don't want that to happen. CDC estimates that so far this season, there have been 24 million illnesses, 260,000 hospitalizations, and 16,000 deaths from the flu. There have been years where we have had 40,000 deaths from the flu. So again, we didn't have this scary triple pandemic that people were worried about. The cumulative hospitalization rates in the flu ServNet system was 1.8 times higher than the highest cumulative in-season hospitalization rate observed for week 1 during the previous season, going back to 2010 and 11. However, this in-season rate is still lower than end-of-season hospitalization rate for all but 4 pre-COVID-19 pandemic seasons going back to 2010. In other words, what I'm trying to say here is that yes, we still have high flu levels and we have high cumulative hospitalization rates, but nothing like we have seen in the past. So it's actually going pretty well and hopefully will end soon. The number of flu hospital admissions reported in the HHS Protect system decreased compared to week 52. Majority of influenza virus tests are in the same genetic subclade as antigenally similar to the influenza viruses included in the vaccine, as I mentioned. So if you did get vaccinated, you are protected. All viruses collected and evaluated this season have been susceptible to influenza antivirals. So Tamiflu is one. So if you start to get you're feeling bad, you go to the doctor, you're running a fever, get on Tamiflu as soon as possible because it will, according to your doctor's recommendations, of course, because of possible drug interactions. But there are other agents that are out there that can lessen the severity of the flu. Even in cases where say that you were vaccinated 5 days ago and you end up getting the flu because you didn't have time to form complete antibodies, the antibodies that you have will fight against it and make your symptoms less. The CDC continues to recommend that everyone ages 6 months and older get the annual flu vaccine as long as flu activity continues, and we still have flu activity. CDC issued interim guidance for clinicians to prioritize antiviral treatment of influenza in the setting of reduced availability of Tamiflu through the Health Alert Network in December. So people were getting prescribed Tamiflu, they were sort of running low, but we haven't heard of any cases at a hospital where we've had a problem. So I would check with your local areas. We have not had an issue of getting Tamiflu. So there are some barriers to people getting this vaccine. And I don't know whether all of this discussion about vaccinations and anti-vaxxers is playing into this. However, there are myths out there that you really need to talk. And we do this every year with staff. Although if you work in my hospital, unless you have a medical reason, you have to get the flu vaccine. So 1, you can catch the flu from the vaccine. There is no virus, there's no active virus in the flu vaccine. It does not give you the flu. However, like my case, it takes a couple weeks, 1 to 2 weeks to form those antibodies. I was exposed a couple days after I got the vaccine and ended up with the flu. Did I get the flu from the vaccine? No, I got the flu from my spouse. So we were basically sick at the same time. Healthy people don't need to be vaccinated. You don't need to be immunocompromised to get the flu. I am not immunocompromised. You don't need to get the flu shot every year. The flu variants change every year. And based on what we see in the Southern Hemisphere, we try to figure out what's going to happen in the Northern Hemisphere. We noticed that the Southern Hemisphere this year did not have a severe flu outbreak, and the same is showing up in the Northern Hemisphere. You need to get this flu shot every year. Another myth, pregnant women can't get a flu shot. The flu shot is actually highly recommended for pregnant women, as pregnancy can cause immune, heart, and lung changes that increase the risk for flu. The severe respiratory infection and high fevers associated with flu can lead to serious pregnancy complications. People with egg allergies can't get a flu shot. Well, we know we have a vaccine now without eggs, but there's such a little bit of egg that really won't have a serious vaccine. Again, don't take my word. Please check with your primary healthcare provider on whether you should get the flu vaccine or what type. If you get the flu, the shot didn't work. We've already talked about that, and I won't go on to that. Getting the flu vaccination is all you need to do to protect yourself from the flu. That actually is not true. Aside from getting vaccinated protection, the flu can be vaccinated by frequent hand washing, which is why I mentioned it, avoiding contact with people who have the flu, which I regretfully could not. If you're exposed to the flu before vaccination, ask your doctor about antiviral medications. The flu is just a bad cold. No, I've had a cold before. It didn't knock me on the tush. The flu is much more serious. It can lead to several deaths. This year, not this year, but in previous years, 36,000 deaths have occurred and more than 200,000 hospitalizations. Flu can include GI symptoms like nausea, vomiting, and diarrhea. The term stomach flu is actually virus. It's not the flu. And so we don't write antibiotics for that. And antibiotic stewardship in the dental practice is something we really need to be aware of, and also work with our medical providers on that. You can't spread the flu if you're feeling well. Nearly 30% of people carrying influenza virus have no symptoms. Up to 50% of people who have COVID are asymptomatic or pre-symptomatic. That's why in my practice and my recommendation that during the season of high respiratory infections, this is why even though we're changing the title of our presentations, we're concentrating on what's occurring now. We need to take all of the respiratory transmission precautions because you don't know if someone has the flu or not when they come in. If 30% of people have influenza virus have no symptoms, they can still transmit. So protecting our staff, protecting our families, again, is so important. Myth 11, if you have a high fever with the flu that lasts more than a day or two, antibiotics might be necessary. Again, this is a viral infection. The antibiotics do not work against viral infections. They also don't prevent. So we have to be careful with how we use our antibiotics, because seeing the path of new antibiotics showing up in our system, that's been slow development. We've seen much faster creation of antivirals than we had seen of antibacterials. So again, we need to save our options. The vaccine efficacy rate. There's good news from the Southern Hemisphere, as I mentioned, that just concluded their flu season. Chile, for example, found the flu vaccine was a good match for the current strain. They're reporting almost a 50% efficacy rate, but only 28% of Americans are vaccinated against the flu. This is almost 10 percentage points lower than pre-pandemic rates. I'm actually not going to say this is frustrating or disappointing. We have to take the politics out of vaccines. We have to get back to the point where we trust our CDC, where we trust Health and Human Services, where we have like our patients trust us to do the right thing. We also have to have that trust in our physicians and where they get their information. And that's why the CDC is doing some changes now to try to regain the trust of the American public. I trust the CDC. It's not because they're in Atlanta and I'm in Atlanta. It's not because I've worked with some incredible people and know some incredible people at the CDC, and I'm very grateful for the work that they do. But in our current polarized environment, vaccination has become a part of the discussion, and it should not be. We want to keep people healthy. Healthcare providers should consider RSV in patients with respiratory illness, particularly during the RSV season. This virus was discovered in 1956, probably around the time that Dr. Severance was born, just kidding, and has since been recognized as one of the most common causes of childhood illness. It causes annual outbreaks of respiratory illness in all age groups. In most regions of the US, RSV circulation starts in the fall and peaks in the winter. The timing and severity of RSV season in a given community can vary from year to year. Scientists are developing several vaccines, and there was just some news about a new vaccine that is 83% effective in adults in preventing RSV. I don't even want to talk about vaccinating against this yet because we can't get people vaccinated for the flu or COVID. But know that there are vaccines in development that are showing great results in adults. Monoclonal antibodies are still effective, and the antiviral therapies to protect infants and young children, pregnant women, and older adults from severe infection. Each year in the United States, RSV leads to approximately 2.1 million outpatient visits amongst children younger than 5. We've all seen our televisions on the news with our children's hospitals being overrun with RSV earlier in the season. 58,000 to 80,000 hospitalizations amongst children younger than 5 years old. This year was worse. 60,000 to 120,000 hospitalizations amongst adults 65 years and older. 6 to 10,000 deaths amongst adults 65 years and older. 100 to 300 deaths in children younger than 5, and that is just awful. We can do something to prevent this, to protecting our children. We need to look at that. RSV is most common during the winter virus season between November and March. It spreads by droplets expelled by coughing and sneezing. It is not aerosolized that we're aware of, or in infected surfaces or come in contact with the nose, eyes, and mouth. Again, in the DIL setting, this should not be an issue. We have gloves, we disinfect in between patients, we have shields, masks, etc. 2 out of 3 babies will get RSV before they are 1 year old. RSV can go from cold-like symptoms to a hospital stay in less than a week, and I think we've seen that, although the number is starting to go down. Although hospitalization occurs in only 1 to 2% of RSV cases, it is not possible to predict which baby will be hospitalized. Babies are 16 times more likely to be hospitalized for RSV than the flu. Again, this is a serious illness not to be taken lightly. So how would we tell as parents, or how do we tell when, because we might be doing well child visits and doing some 1-year exams and 2-year exams. RSV infection can cause a variety of illness in infants and young children. It most commonly causes a cold-like illness. It can also cause a lower respiratory infection and diseases like pneumonia. Infants and young children with RSV may have a runny nose and a decrease in appetite before any other symptoms appear. Cough usually comes about 1 or 2 days later. Soon after the cough, sneezing, fever, and wheezing may occur. And very young infants, irritability, decreased activity, and or apnea may be the only symptoms of infection. So if you have a sick child, I know you're taking them to the pediatrician. Adults who get RSV usually have mild or no symptoms. Symptoms are usually consistent with an upper respiratory tract infection, which can include, again, a sore throat, a runny nose, cough, headache, fatigue, and fever. Disease usually lasts less than 5 days. Some adults, however, may have more severe symptoms consistent with a lower respiratory infection, such as pneumonia. Those at high risk for severe illness include older adults, especially those 65 years and older, adults with chronic lung or heart disease, COPD, or other kinds of heart disease, adults with weakened immune systems, such as those that I manage on a daily basis. RSV can sometimes also lead to exacerbation of serious conditions such as asthma, COPD, and congestive heart failure. There is a monoclonal antibody that is recommended by the American Academy of Pediatrics to be administered to high-risk infants and young children likely to benefit from immunoprophylaxis based on gestational age and certain underlying medical conditions. It is given monthly through an intramuscular injection during the RSV season, which, as I mentioned before, starts in the fall, peaks in the winter in most parts of the United States. So what about monkeypox or mpox? Because we have changed the name. I think the one thing I would like to say is that this has been one of the most impressive combinations of community response and a federal response that have led to a better outcome. The community impacted was notified. There were vaccines that were available. People took to the vaccines where they would see the highest rates of this disease. Community and public health came together, and now we only see about 2 cases of this a day in the United States. So we had this huge level of people showing up with these awful ulcerations, this awful disease. The community responded, public health responded, and to a large degree, we have eliminated mpox. And that is remarkable. Does it mean that it's over completely? In the United States for now, yes. What we're really looking, but if there are still people of color that don't have access to the vaccines, so we really need to reach out to them. And actually the federal government and communities are doing that. So the key point is there might be another global outbreak. We'll keep our eye on it. If something happens, we'll definitely let you know. I did want to talk about this occupational needle stick exposure to mpox that occurred in Florida last year. They were notified about a nurse who acquired mpox through an occupational exposure while providing care. Basically, what happened was she was trying to get a good swab. So she got a needle and probably a butterfly needle. And what she tried to do was to poke the needle to get some of the fluid to come out so she would get a good swab. She was opening a vesicular lesion. The needle stick occurred when recapping the used needle by hand before disposal. We don't recap needles by hand. And in the medical environment, they have many more safety devices than we have in dentistry at this point. So what happened was it caused a break in the skin in the index finger of the nurse's gloved hand, accompanied by a small amount of bleeding. The wound was immediately washed with soap and water and drenched with betadine antiseptic solution. I don't know what that would do, to be frankly honest, but it was cleaned. The incident was reported to the hospital infection control practitioner, et cetera, and the lesion swab from the patient tested positive for orthopox using PCR. Within approximately 15 hours of the incident, the nurse, who had no relevant past medical history or previous orthopox vaccination, received the first dose of the vaccination as post-exposure prophylaxis. 10 days after the exposure, a single skin lesion formed at the site of the needle stick. The nurse immediately began isolating at home, kept the lesion covered until it had fully crusted over, the scab had fallen off, and a new layer of skin had formed beneath 19 days later. Apart from the single lesion at the puncture site, no additional lesions or other clinical signs or symptoms did show up. No secondary cases were identified. So that is the first occupationally acquired mpox infection in the U.S. healthcare worker during the 2020 mpox outbreak. CDC advises against unroofing, opening, or aspirating mpox lesions with sharp instruments and recapping used needles because of risk for sharp injuries. We don't do that. That's not part of our goal, but I did want you to be advised that although we've never had a documented case of HIV transmission from a patient to a dental healthcare worker, since HIV has been around almost 40 years, we did have a case of occupationally acquired of mpox, not in dentistry. And the comment I made about HIV was about the dental healthcare workers. So we don't do this, we don't mess with this. But again, if we are gloved, we are gowned, we're not at risk. So as always, it's been a pleasure providing this information. I look forward to your input on areas that you'd like us to cover in the future. Again, it's always a pleasure to talk to you on these webinars. I look forward to speaking to you in the future. And I'm turning it back to my good colleague and Dallas Cowboy fan, Dr. Gary Severance.
Thank you, Dr. Reznik. Great to have you on board for this new series, Health Concerns in Dentistry. And no, I wasn't born in 1956, but close. And thank you for the Cowboys shout out. It's probably the only episode we can mention it in. And thank you for watching. Please subscribe to our YouTube channel by clicking the subscribe button below. And to be notified of any new episodes, click the bell icon. Also, if you have any questions, concerns, or topics for future episodes, please email us at webinars@henryschein.com. With that, we'll see you next time. Stay safe and stay informed.